Hello, everyone, and welcome. My name is Susan Fishbein, and I am the facilitator of the HSS Myositis Support Group. I'd like to welcome everyone and thank you for joining us as we continue in our celebration of Myositis Awareness Month. We are here to honor people who are living with myositis, their families, and their loved ones. The program is made possible through the collaboration of the Department of Social Work Programs and the Division of Rheumatology here at Hospital for Special Surgery. We are also celebrating the 27th anniversary of the Myositis Support Group, which I have had the honor and privilege of facilitating for the past 16 years. We are dedicated to offering support and education for people with myositis and their loved ones, and to provide a sense of community for people with this rare illness. Even during the difficult times of the pandemic, we were able to come together and stay connected through our monthly support meetings on Zoom, which many of us learned to manage, even when we thought we were technologically challenged and unable to do so. And we continue in that format. For those who may be unaware, I'd like to offer just a brief history of how we came to be the only myositis support group in this area. Together with the Division of Rheumatology, the Department of Social Work Programs developed this group, which has been meeting since 1997. We began with only 6 founding members, and it was led by a social work student intern. The group ended with her academic year, but because group members felt it was so important to have a place for people with this rare illness to feel like a community, their voices were heard loud and clear in advocating for this group to continue. And continue it did. We now have over 150 members. In addition to offering support and education for people with myositis and their loved ones, we are also committed to raising awareness for myositis. We want to see a time when myositis is considered more often in making a diagnosis so that treatment may begin sooner. One way we do this is by presenting monthly programs that include our expert speakers on myositis. Topics are chosen through feedback from members and suggestions that are raised during group meetings. Several of our programs are now available on the HSS YouTube channel, as this program will also be. This becomes a valuable resource, especially for people who are seeking help with myositis and who may have very limited access to care and treatment. Now about today's program. Dr. David Fernandez, our group's esteemed medical advisor and physician to many people with myositis here at HSS, will present on updates in myositis treatment and research. Dr. Fernandez is an assistant professor of rheumatology at Hospital for Special Surgery here in New York, with a focus on the care of myositis patients, as well as translational research centered on inclusion body myositis. He completed his MD, PhD training at SUNY Upstate Medical University in Syracuse, New York, before coming to New York City for an internal medicine residency at Weill Cornell Medicine and a rheumatology fellowship at Hospital for Special Surgery. His current research with colleagues at HSS is focused on single-cell RNA sequencing of CD8 positive T cells from blood and muscle of inclusion body myositis patients. He has been a site investigator for several myositis clinical trials at HSS, some of which are currently ongoing, and is interested in collaborating in clinical and translational research efforts. Dr. Fernandez will speak for approximately 1 hour. Questions may be entered through the Q&A box at the bottom of the screen and will be addressed at the end of the presentation when the recording is then stopped. Please be mindful that Dr. Fernandez will not be able to answer specific questions about your individual care and treatment. As always, this is best addressed during visits with your doctor. Your thoughts and opinions matter to us greatly. Please take time to answer a brief anonymous survey that is provided in the link in the chat box at the bottom of the screen. This can help to give us information about how to develop programs that address the needs and issues that are most relevant to you, and also gives our speakers feedback on their programs. I've said it many times, and I'll say it again, words cannot truly express the gratitude and thanks we feel to Dr. Fernandez. His dedication, his caring, his compassion, and his vast knowledge have helped so many people with myositis. And many thanks to you, our members and friends and family, for joining us today. I'd also like to thank Mr. Demisvar Destin, who was working behind the scenes to help make this recording possible. Our meeting will end promptly after the question and answer session. Without further delay, I'd like to present our guest speaker, Dr. David Fernandez.
All right. Well, thank you so much, Susan, and thank you to all the participants who've come to hear me speak. I'd like to give you some updates about myositis research, just some things that that grab my attention that I think that would be of interest to you all over the past year, as well as a couple of things that I like to highlight each year, just because I think that they're of particular importance. I also tried to trim back some of the technical details, although I couldn't help myself about some of them. And so, please let me know if I overcorrected. All right. So here's just a brief outline of the things I'll speak about. So just a, very brief overview of myositis research, as well as the epidemiology of myositis, and then topics on disease monitoring in myositis, autoantibody testing and research in myositis, exercise in myositis, then updates and treatments, and I'll wind up with just a very brief mention of some of the research that we're doing at HSS as well. All right, so I showed this diagram every single year, and it's been neat to see how it's evolved over time. But there's this very large and exponentially growing body of literature in myositis, and so if you just search for myositis, you get over 27,000 results, and there were 1,300 unique results just last year. And so the pace of discovery is really accelerating and moving rapidly. All right. So I'll start with epidemiology of myositis. And so this relates to, this is a study that came out of the Mayo Clinic looking at the prevalence and incidence. So that's the total number of people affected by dermatomyositis, as well as the number of new cases annually. And there's been a change in the number of dermatomyositis patients that have been identified in more recent studies relative to older studies. And what this most recent study found was that there were new cases that were present. There was about 1 per 100,000 people in this part of Minnesota. And then the overall number of patients about 13 per 100,000. And that was more than had previously been estimated, even in prior studies at that site. And it's on the higher end of estimates that have been published in different countries and different areas. And so they thought that there were a couple of reasons why that might be. There have been a number of changes in identifying patients, and I think probably for the better, that patients that may have been excluded in the past or misdiagnosed are now being appropriately diagnosed. And this number includes clinically amyopathic patients, so patients with principally skin-limited disease, although it is entirely possible that there is a rise in cases of dermatomyositis over time, and it will take subsequent studies to get a sense of the general trend in that direction. Of course, Minnesota is a very is a relatively ethnically homogeneous place. So, this is a limited snapshot of the disease, but it's still a well-done study that gives us a picture of dermatomyositis in this area. All right. This is a separate way to look at epidemiology of myositis, and it addresses a question that comes up pretty frequently in patient visits. And the question is, when someone has this condition, they want to know what is the risk of their family, of their children, of other people that they love. Will they also be affected by the disease? And so this is a nice way to put numbers on it, that the study from Sweden is able to start to address that question. So they identified about 1,600 patients and a number of family members that they have registries that link all of those records together and allow you to ask this question in a big, in a powerful way. And they were able to match those patients or compare them to people of similar age and their relatives. And what they found was that the patients with myositis were more likely to have a first-degree relative with what they called other rheumatic inflammatory diseases. So there was several that they combined into one group to make the analysis a little bit simpler. And they saw that it was about say a 30% increased risk of a first-degree relative with Sjogren's or lupus, scleroderma. However, that 30% is a really small number. It's a 30% on what is a small number to begin with. So it's 1.37% versus about 1%. Okay, so there's an increase, but it is relatively subtle. And the same is true across other diseases. So inflammatory bowel disease, autoimmune thyroid disease, celiac disease, you could see measurable differences. Of note, I just want to point out the thyroid disease, it's a smaller impact. This is a more common condition, the thyroid disease. But it's, but the added risk of having that because you have myositis is low. Notably, they did not see any increased likelihood of having relatives with rheumatoid arthritis or diabetes or multiple sclerosis or myasthenia, unlike some studies with lupus. And similar results were seen in a different study that was using the Taiwanese national database. So I think the take home that I would give patients is that the most common situation is that a single person in a family is affected. And there are certainly families where that are the exceptions to that, but for the most part, the increased risk is relatively modest. And this is just a sort of a visual example of that. This is a different study looking at lupus. So it's a different thing entirely. I just want to focus on the scale. So you can see that the general population risk of family members with lupus is this white line at the bottom. There's very few, it's a very low risk. So this percent over here is less than 1%. And if you have a first-degree relative with lupus, it's higher, it's up to 2%, but it's still 2%. It's not a very big number. It's not a guarantee. All right. So let me speak about disease monitoring in myositis and some things that are of particular relevance to patients. So one of the things that there have been some pretty important advances in that have involved a lot of patient input has to do with the recognition and appreciation of pain as a burdensome symptom in myositis. And this took a while and this was overdue. The classic description of myositis in medical school textbooks was that of painless weakness, that patients, just were unable to do certain tasks with their arms or legs, but that that was it. this is far from universal. And if you actually look at the old data with some scrutiny, you'll see that even there, they reported something like 30% of patients having significant pain as part of their presenting symptoms. And a number of studies came out just in the last year that confirmed this and sort of attach some concrete numbers of magnitude of this impact. So this is one study by Shinjo et al. Looking at a survey of patients from across the world, and they found that the average pain score was about 2 in myositis, 2 out of 10, but that with a significant variance around that. So some people had very little, and some people had significantly more pain. And it was kind of in between. It was a little bit less than patients with certain other autoimmune diseases, so things like rheumatoid arthritis, but it was worse than the control subjects that they had enrolled. And they found that among folks with myositis, it was more likely to be a problem in patients with antisynthetase syndrome or overlap myositis. So the myositis present along with another autoimmune disease. And these other two studies by Didem Sagan at Pittsburgh, so they use the PROMIS instrument, which is a different kind of questionnaire-based pain assessment. And they found that the majority of patients scored above average on pain scores using that instrument. And almost all patients reported pain interfering with at least some aspect of their function in daily life. That's really a very different kind of perspective than you'd get from the painless weakness that was the lore that medical students used to get. This was another study that came out of Pittsburgh, and they had done a number of pain instrument assessments on 50 patients. And about half of the patients in this case showed at least moderate or severe disease, severe pain on each of those things. And that pain was linked with other measures of disease activity. So it wasn't just that they had pain and it was just, sort of unrelated. It was that, they had weakness, they had lab changes that fit with muscle disease, and that corresponded with pain. So it's another important observation. All right. And all right, so then this study was is slightly different, but also gets at that issue of the distinct perspectives of patients and physicians. And so this was looking at measures that are used in clinical trials. So one of the common ways that you look at disease activity in clinical trials, you do, it's called a global activity measurement. So you look at a line that goes from 0 to 10, and then you mark kind of where you are today on that line. So 10 is the kind of the worst imaginable, and 0 is fine, and you sort of pick. And frequently, the patient and physician assessments diverge, and they diverge in part because of the kind of the relative emphasis on different factors. And so what they found in this case is that when the patient and physician global assessments diverged, they looked at what else the patients assessed, what else they noted, and they found that where it was divergent, the patients were more likely to have pain. That was more likely to be a bigger problem that perhaps the physicians were less able to perceive. They had more prominent fatigue, and that fatigue translated to functional consequences. So if you looked at step count using an actigraph, that was measurably lower, almost by half, in the patients who rated themselves as doing worse than their physicians, and they scored worse on disability measures. So it's an important thing that that these assessments can diverge, and that there maybe are things that we don't capture as part of the visit unless we specifically ask about it and focus on the patient perspective, that have functional measurable consequences in terms of function and mobility. All right. So this, I just want to speak very briefly about autoantibody tests. So this is one of the areas of real progress over the last several decades, identifying specific autoantibodies. These are blood tests that show the capacity of the immune system to react to specific self proteins or RNA molecules or a mix that correspond to specific general disease presentations. And so these are very helpful in terms of diagnosing patients with the disease and also predicting what are the disease manifestations that are likely to present in a given patient. And so one way in particular that these tests are useful is that the antibody pattern can help to define the risk of cancers. And so dermatomyositis in particular, but myositis in general, can sometimes be seen in the setting of cancers. And roughly about, say, 15 to 20% in the case of dermatomyositis. And there are two antibodies that are clearly associated with cancer risk. I guess before I say that, let me say, just to clarify, the risk of cancer is not general. It's not a permanent state. What is felt to represent is an effort by the immune system to fight off the cancer. And because the cancer shares features with skin and muscle, that results in injury to those other tissues that show up as the symptoms of dermatomyositis. And so the highest risk of cancer is at the time of symptom onset. So sometimes it's in patients who have a pre-existing cancer and one day they develop these symptoms. Other times it's people who present, and then if you go looking, you can find evidence of cancer. So the risk is highest early in the disease process, and then it lowers back to normal roughly within about 3 years of disease onset. And it's been shown that there are a couple antibodies that are clearly associated with cancer risk. So the ones that are most closely associated are the TIF1 gamma and NXP2. And interestingly, there's evidence of mutations in those targets, in the proteins that those antibodies target, in the tumors of patients with cancer-associated dermatomyositis who have that antibody. Now, importantly, while if you ask the question one way, are the patients with cancer more likely to have one antibody or another? The answer is yes. But if you ask it kind of the opposite way, does the antibody being there mean that I have cancer? And the answer is no, that the majority of patients with that, even with that high-risk antibody, do not have cancer. That's an important distinction to make. And this was an updated study that had just come out last year, looking at 66 patients with dermatomyositis who had cancer develop within 3 years before or after the disease was diagnosed. And the majority tested positive for TIF1 gamma, and then a large group were either positive for MI2, SAE, or NXP2. And importantly, they did not identify a particular cancer signal with anti-synthetase antibodies like JO1, the HMGCR antibody, or MDA5. It's not to say that it's impossible, but the risk is much closer to the general population risk than it is with these other high-risk antibodies. There's also an impact from age. So TIF1 gamma antibodies are very common in children, but essentially zero malignancy is seen in children who are afflicted with juvenile dermatomyositis. All right. And that helps to shape some recommendations that were recently promulgated regarding cancer screening. So if somebody presents with new onset myositis, it's important for them to undergo some screening to look for cancers that are not yet obvious clinically. And so it sorts patients into different risk groups, in part using these risk profiles. And then the screening varies depending on the risk. So the highest risk groups get the most screening. Right. So this one, so I just want to speak about this new finding looking at autoantibodies and myositis. And it's, please forgive me if it's a little technical, but I think it's really exciting. It was presented at this year's Global Myositis Conference. And yeah, well, I'll just dive in. So the basic idea had to do with autoantibody internalization in myositis, and I'll explain what that means. So the way that the study began was this group at the NIH was looking at the genes that were turned on and off in muscle of patients who had different antibodies. And they sorted them into different groups, and they had a very big group of patients to examine. So they had a group with MI2, a group of dermatomyositis who weren't MI2 positive. They had some necrotizing myopathy patients, some patients with inclusion body myositis, and some patients without a diagnosis of muscle disease. And what they found was that there was a specific set of genes that were high just in the patients with the anti-MI2 antibodies. And so this is, the names aren't that important, but it was just in that group. It was not found in the normal muscle. And what was interesting about these genes in particular is that the expression of these genes is regulated, is controlled by the protein that is targeted by the MI2 antibody. This one, the CHD4 NURD. So that was surprising. And what they saw when they looked under the microscope, they could see, what if we look at that protein, those proteins that are upregulated, that are increased in expression in patients with MI2 antibodies. So SCRT1 is an example of that. They see that they find that is present in the nucleus of muscle fibers. So you can see the green color is the SCRT1, the host is the nucleus, and they line up more or less exactly. Then if you look at antibodies, so IgG, and you line that up with the nucleus, you see that antibodies in some of the myofibers show up as this teal color, meaning that the green antibody is also present with the blue nucleus. So antibodies are normally outside of cells. They're not normally inside, but they find that the antibody is present at the place where the protein is. And the inference, at least the possibility, is that the antibody test, we wonder why certain antibodies are associated with certain disease manifestations. And so one possible implication of these results is that the antibodies may help to shape some features of the disease itself. And if you look at, so they followed up and they looked at other antibodies. And so they're looking again at different antibody specificities. And what they found was that if you stain with the antibodies in people with different autoantibody specificities, you can find the antibodies in different places that correspond to the target that it binds to. So the MI2, like we said, it's in the nucleus. MDA5 and HMGCR. MDA5 is associated with a type of dermatomyositis, and HMGCR is associated with a necrotizing myositis. That's seen in the cytoplasm. And this PMSCL is seen at the center of the nucleus, called the nucleolus. You can see it's very obvious right there. It's this little kind of core. And then if you force antibodies, if you actually open the cells and put antibodies inside the cells, they activate the same genes that are linked with the disease. And so it seems that the antibodies, there's a lot of circumstantial evidence linking the antibodies being inside the cells and the genes that help to drive disease activity sort of all coming together. And so the way that this group is conceptualizing that is that there's antibodies that are getting inside muscle cells, that the antibodies can affect the function of the target, and that leads to cell toxicity or inflammation. So in MI2, it blocks the function of that NURD complex, and you get extra expression of those genes that are normally blocked. So I hope you find that as exciting as I did, but I thought that was really incredible in a way that ties together the antibody, the different types of antibodies and how they may differ across different patients, and the actual disease manifestations. And so some of the things that have not been explored but could be are whether the same thing is happening in skin or lung or other tissues, and so we hope to see those results in coming months and years. All right, so I'll turn back to exercise in the treatment of myositis. So I just want to emphasize broadly that this is extremely important in all forms of myositis. And it's a little counterintuitive, but there's no sign of increased risk of flares or worsening of disease with exercise. So that studies show that physical therapy is safe at essentially any stage of disease activity. Though I would just say, within reason, that it's important to listen to your body, that the point of exercise is to make yourself better and not to, get hurt or to overdo it. But as long as you proceed incrementally, it should be on net beneficial to almost everybody. And if you look at a molecular level, there's also further benefits that are seen, even on the level of inflammation or lactic acid production, and specific types of exercise are being evaluated in ongoing studies. So some important updates that had come up, I think are, so one was this observation in inclusion body myositis. And, as we know, exercise is a key component of an inclusion body treatment protocols. And one thing that I've observed in patients, and that other physicians who take care of these patients have observed, is that patients will often suffer functional setbacks following hospitalizations or surgeries or other procedures. And so there was a study in Japan looking at the kind of the intensiveness or how much rehabilitation people were able to do. And they found that the more rehabilitation that people got, the better they did. And so patients who are getting 1 hour a day of exercise, like in a formal rehabilitation center for a longer time, did better than those who received less than that, or who had more intermittent therapy. And those getting 6 days of therapy, sort of again, more like subacute rehabilitation center kind of model, did better than those who were getting fewer days of therapy. And, I think unfortunately that is not feasible in most hospital settings, but I think it's something that perhaps to aspire to, or that it may be a reason to change the kind of general paradigm of sort of more minimal therapy inpatient for these particularly high-risk patients. All right. And then this I thought was a particular interest, helping to quantify some of the benefits of a type of exercise therapy. And so there were two studies. So one, this study by Brokamp et al. Had shown that patients with inclusion body myositis often will have measurable deficits in lung function and the strength of the diaphragm. And so they found that more than half of the patients had some reduction in lung capacity in one study, and that there was some decline over time. And it tended to relate to the overall strength. So people who had milder disease, that was generally imperceptible, and people who had more advanced disease, it was more noticeable. However, I think really importantly, inspiratory muscle training, so exercise, specifically the diaphragm, was able to show benefit. And so this pilot study from Australia, again, it's a small number of patients, but the proof of principle is important. And so they had the patients undergo a regimen for 8 weeks doing specific breathing exercises. They found that the inspiratory force increased by 50% and the expiratory force increased by 43%. So really sort of not subtle, very big changes. And the lung volume increased by 13%, which is also very impressive. And I think that that shows promise for this type of rehabilitation to improve respiratory function and inclusion body myositis. And I feel like a lot of times in the condition, it's about managing decline. So it's nice to see this example of tangible improvements that are possible. All right. So let me speak about pharmacologic treatment for polymyositis and dermatomyositis. So I'll just touch briefly on the study of IVIG and dermatomyositis. I had spoken about it last year, but I think it's of sufficient import that I want to touch on it briefly again. And so this was a phase 3 study of 95 patients with active dermatomyositis. They were required to have muscle involvement, and the patients, either got IVIG or placebo for 16 weeks, and then everybody got it for 24 weeks. And the primary outcome was this total improvement score, and 80% of the patients on IVIG met the primary outcome versus 44% of the placebo patients. So that was a successful study. And on that basis, IVIG is now FDA approved for a treatment of dermatomyositis. And I think one of the important points that I like to make is that if you look at the folks who are enrolled in the study, their creatine kinase levels were pretty normal. And that did not impact, their weakness. They still were quite weak. They still had capacity to improve with therapy. So the enzymes are not adequate to capture all of the disease activity. That much more focus ought to be paid to strength and then kind of dynamic changes over time and patient function. Now, there are some important side effects with IVIG, and as I like to say to patients, they're related to the size of the dose and the speed at which you give it. And so the big dose back to back is the highest risk, and then more spread out that decreases the risk. So they saw a lot of headache. Headache was quite common. They saw fevers and they saw nausea. Those were commonly reported. And then importantly, they saw clotting events in a number of patients. They did some further studies of this, and they showed that most of the patients who had clots had other risk factors for clots, like severe immobility or other reasons why they were prone to that. And that importantly, what they also saw was that if you had some problem with the very tightly spaced dosing, that if you spread it out, patients who were getting the spread out dosing did not have any clotting events. So that was also important. This was another study. This is coming out of the Brigham, and this was trying to kind of put the clotting risk into perspective. So the IVIG actually has a warning about clotting risk, and it's just strange because it's not something that comes up all that often in people who use it frequently. And so, but what is true is that dermatomyositis is itself a risk factor for clotting, independent of IVIG. And so this study sought to look at all of the dermatomyositis patients in their system and look at clots that happened and see if they were present in relation to what their relation was to IVIG treatment. And they found there were 23 clotting events. 3% of patients on IVIG had clotting events, and 6% of patients not on IVIG had clotting events. And a number of them occurred in patients who had cancer, which is a risk factor for clotting separately. So they said that there was no clear association between IVIG treatment and clotting risk, and that these other factors may be more important as well as some of the nuances of the dosing. All right. So this study, this was a different agent. So this was a smaller study that was done. It was coordinated by colleagues at Northwell, and they were using this agent belimumab to treat patients with polymyositis and dermatomyositis. And belimumab, it blocks a specific protein called B cell activating factor, or B lymphocyte stimulator, so BAFF or BLIS. And this is indicated by the FDA for treatment of lupus. So it's been demonstrated to be helpful in that condition. So they wanted to try it in patients with myositis. It's a relatively small study, so they enrolled 17 subjects, and 15 of whom received more than 5 doses. And they saw a numerical difference in outcomes. So the patients who were getting the belimumab were more likely, or more of them reached this moderate improvement threshold. But as I think because of the numbers, this was not statistically significant. It's impossible to say for certain without, a bigger study. But yeah, so this was thought-provoking and potentially could be an option in the right setting, or the basis for further study. Importantly, there were no new safety signals, so this is a drug that's generally well tolerated in lupus, and there wasn't anything different that was observed in patients with myositis. All right. Then there was a study, an older study that I just wanted to highlight briefly, and then a new prospective study that I'm excited about. And so this is from a group in the Netherlands. And so is a small study that was done looking at patients with new onset myositis. And so it's a mix of polymyositis and dermatomyositis and necrotizing myositis. And they took patients with early disease, so less than 9 months of disease, and they treated them with IVIG alone without anything else. And so of the patients that were enrolled, 8 of them reached the moderate improvement threshold by 9 weeks. And then 7 patients did eventually require other medications. But a lot of them, had a pretty satisfactory response to just that by itself. They did note that 1 pulmonary embolism was seen. And so they're doing a follow-up study. It's called the Time is Muscle study. And in this case, what they're doing is they're using a combination of steroids and IVIG together versus steroids alone to see if the combination is better than just the steroids alone. And they're looking at outcomes by 12 weeks. And I think, it's very likely that the combination will be better, but we'll wait for the final results. But I think that is important, and it leads to this other sort of question about sort of windows of opportunity and how aggressive to be in treating polymyositis and dermatomyositis. So it's hard to know how aggressive to be, and there isn't a lot of head-to-head data. There's not a lot of kind of affirmative reasons to say if you do more up front, are you going to be better 5 years, 10 years down the road. Even though, I think that is relatively intuitive. More medications can have more side effects. We do know that delays in diagnosis and treatment, so people who go for years without being accurately diagnosed and then start treatment, have more time to accumulate damage. Those patients often do worse in the long run than patients who are recognized sooner. And that myositis is easiest to treat earliest in the disease course. And that's similar to other diseases that rheumatologists treat, like rheumatoid arthritis. In particular, there's very good data that patients who are treated within 6 months of disease onset have a much greater likelihood of remitting fully than patients who are encountered later. And so So there's just a couple of observations. So one study had shown this little kind of additional insight, and this is in patients with MDA5 positive dermatomyositis. So that is a type of dermatomyositis that's associated with severe lung disease commonly. And this group was comparing, this is a Japanese group, and they were comparing the patients using their study protocol, which was using 3 medicines simultaneously right off the bat versus just 2 medicines. So in contrast to what was seen historically, the survival was 100%. So they actually didn't have any patients die from this, which, unfortunately can happen. And so that already was a success. But they noted that in the long run, the folks who had gotten the more aggressive therapy up front had a higher rate of being free of flares, so 90% versus 56%, and off of these are calcineurin inhibitors, so things like cyclosporin or tacrolimus, as well as off of steroids. They're much more likely to be off of all medicines in the future if they were treated more aggressively initially. Sort of fitting with that intuition. And I guess I'll just editorialize a little bit. I think that this is, my practice is generally to treat patients with combination therapy or with multiple agents early. And that and I think that a lot of that has to do with my expectation of what is possible. And that it's important for patients to understand that when they're initially diagnosed with polymyositis or dermatomyositis, normal or near normal function is possible. So it's impossible to guarantee anything, but that is an important goal. And if you don't try for it, you won't get it. So the progress towards normal should be evident. So as you're treated, you should see steady improvement, and you should see sort of a trajectory, a path towards where you want to be. And if you're not getting there, and it doesn't seem like you're getting there, and you're kind of on a plateau, then something about the regimen should change. And, or at least you should have a discussion about the merits of changing and the risks. And I think it's particularly important to minimize steroids, that the steroids, they're invaluable in the short term. They work very well against a very wide range of things. They work very rapidly, but they have a lot of side effects that manifest very predictably. So minimizing steroids rapidly is an important part of a good long-term outcome. All right. So I want to speak briefly about this new therapy, the chimeric antigen receptor T cells, or CAR T cells. And so this is a technology that was developed to treat cancers. And what it is they take T cells from patients and they engineer them to target types of tumor cells. So there's a protein on the outside, a binder. It's usually like an antibody or part of an antibody. And it's stuck to a T cell protein on the inside, so that when the antibody sticks to its target, the T cell is activated and the target is killed. So that generates a very strong anti-tumor immunity, and these have been approved for treatment of a number of cancers. And the same thing can be used to treat, can be used in autoimmune disease. So in a sense, it can behave similarly to rituximab, which works by, it's an antibody that binds to B cells, the type of white blood cell, and removes it from the circulation. It kills those cells. It takes a while for those cells to grow back. So this is doing that same thing, but more effectively. And there are some limitations. It's labor intensive. It requires inpatient hospitalization, at least for now, and requires conditioning treatment. So that is actually like a low-level chemotherapy treatment to make space in the bone marrow. You need to have a place for those cells to go and then expand. And if you don't do that, it doesn't work. So, and then, there's a couple of other caveats. So there can be some side effects up front. Those are generally manageable, something called cytokine release syndrome. And there's some uncertainty about long-term safety. This is a new technology. No one has had it, 20 years ago. But but there's reasons to be excited. And so there's a couple of examples. So here's one patient with antisynthetase syndrome who had severe weakness, lung disease, high CKs, had been treated with a number of things with poor response. So he got CAR T cell therapy, and he had a very good response. So all of the things that you would like to get better got better. So his patient global, physician global got much better. His strength got better. His CK went down. Everything got better. The swelling of his muscles on the MRI got better. The lung inflammation, all this white stuff and what should be dark lung got better. And so larger studies are in the planning and preparatory stages. And there have been a couple of other reports recently that have come out. So this one was in JAMA last year. And so again, this is somebody who had failed many lines of therapy who experienced rapid improvement with CAR T therapy. Though he did eventually require CellCept as a little boost to that. And then this was another case, similar, treated with many agents with limited response, but had rapid improvement in arthritis and myositis with the CAR T therapy. There was the longest term follow-up for autoimmune disease was published in the New England Journal in January this year. And they had seen durable benefits in patients with lupus and myositis and scleroderma, and with a generally pretty good side effect profile. So why is it so exciting? Why do people keep talking about it? So there's several things that are encouraging. So one is that there's at least this prospect of long-term remissions that have been seen in at least some of the reported cases off of all medicines. The second is that B cells come back. It's not like they are gone forever. Like if you had to remain on rituximab therapy for your whole life, your B cells would always be like at low levels. That could potentially over time lead to more immune suppression. And that the autoantibodies that we think could contribute to disease activity decline, and in some cases go away in folks who are treated with CAR T therapy. However, this is there's a lot of excitement about it, and the actual tangible experience with this is very limited. So I think it's appropriate that this is proceeding in this very rigorous, trial-driven format. And we're participating in a couple of trials. And so that's in the planning phases right now, and hopefully we'll have that available. And we're working with colleagues at Memorial Sloan Kettering and at Cornell to try to get that up and running. All right, I think in the interest of time, I'll skip over this, but this is just looking at JAK inhibitors. And I've spoken about that a couple of times, but that is a promising therapy for dermatomyositis, and other clinical trials using those agents are ongoing. So let me speak about inclusion body myositis in the last couple of minutes that I have left. So just wanted to speak about rapamycin or sirolimus and inclusion body myositis. And so this was a study of 44 patients with inclusion body myositis, half of whom got sirolimus. It didn't meet the formal endpoint, the way that the trial was designed, but they did see that the patients who got the sirolimus had some, they behaved differently than the patients who got placebo. So they had stable ability to walk, stable breathing, improved measures of function, and they had less MRI changes in the thighs. The side effects were manageable, but they were still, relatively common. And this is an ongoing, there's a larger trial examining this that's being run out of Kansas and Western Australia. And hopefully we'll have some more insight in a sort of a larger population as to how well this medicine can work in patients with IBM. There was a study of testosterone in IBM that I just wanted to touch on. I had spoken about it last year, but I just want to mention it. There was a previous trial with a different anabolic steroid called oxandrolone that had shown subtle improvement in strength in IBM patients. And so this was a follow-up study that was done using just regular testosterone. And they did, it's called a crossover trial. So they had patients who got, half of them got they got the drug for part of the treatment period, and then they crossed into the other group. So then they weren't receiving. And then after that, the 12 subjects did an open label extension where everyone was on the testosterone. And so unfortunately, unlike the previous study, they did not see a difference in the quadricep strength at the conclusion of that study. So it wasn't like the previous one. And while side effects were generally mild, there were some potentially concerning ones. So there were increases in PSA. So prostate cancer is one that's driven by testosterone. And so that is an important concern that requires vigilance in people who are receiving testosterone therapy. And then testosterone drives red blood cell numbers higher. So some patients had higher hemoglobin, and that was another thing that needed monitoring. All right. And then I just want to mention this ongoing study. This is the Abcuro study using this autoantibody, or this antibody biologic agent for treatment of inclusion body myositis. So this has a couple of phases. There's sort of a run-in phase and then a larger phase. So now both are fully enrolled as of May, and the treatment period is going to last 18 months. So this medication targets a protein called KLRG1. It's on the surface of certain white blood cells, and cells with that marker are expanded in the blood and muscle of IBM patients. So if you give the medicine, those cells are removed, and and hopefully that will result in tangible improvement in strength and inflammation and allow for improvement. And so hopefully we'll have some updates about that next year. All right, I think I have a couple minutes. So I just want to mention, we have a myositis registry that we use to study patients. We have about 150 patients currently enrolled. The goal is to gather comprehensive information about myositis patients, and including formal disease activity measurement, and to get blood samples. It's a minimal commitment, so we may request blood samples or do capillaroscopy, so looking at the nail fold capillaries to look at some of the changes that can be evident in myositis. And I'm very grateful to the patients who participated thus far. And I'll skip again. I know time is running short, but this our research that we're in the process of preparing in manuscript form was to look at CD8 T cells in inclusion body myositis, and so we're trying to understand the reasons why these cells can be expanded in inclusion body myositis, and whether patients who have expanded CD8 cells differ from those who don't have that expansion. So our goals in the study are to identify patients with expansions of this particular type of white blood cell, and then to look at the genes that are turned on and off in those cells. And so we have a lot of data about that. And then to identify mutations as like reasons why those cells may be behaving aberrantly and contributing to disease activity. And like I said, we'll have to have you stay tuned, and we should have those results ready in the coming months. So, in conclusion, there are many exciting developments on the horizon. The pace of clinical trials is accelerating. There's lots of things happening in the field. And hopefully this will bring us closer to understanding the causes of myositis, allowing us to design and test better treatments and try to come close to a cure for different forms of the disease. So with that, I'd like to acknowledge my colleagues in the lab, my colleagues in the Crow lab and the Donlin lab, my colleagues in the Scleroderma Vasculitis and Myositis Center of Excellence here at HSS. Of course, I'd like to acknowledge Susan and some of our funders. Of course, I'd like to thank all of our patients and today's participants. And again, just one more time, thank you so much, Susan. And thank you all for your attention. With that, I'll take any questions.